I'm Dave Story. I'm the Chair of Anaesthesia at the University of Melbourne. I'm also a practising staff anaesthetist at the Austin Hospital here in Melbourne.
And Simon Judkins. I'm the President of the Australasian College for Emergency Medicine, and coincidentally I also work at the Austin Hospital.
Thank you both for joining us here. We've just been at the Royal Women's Hospital Grand Round in Melbourne, talking about women in medicine, talking gender equity. It was pointed out that one of the biggest questions in the lead up to the round was why are there two men on it? You were the two men. So what did you bring to this, and what will you take away from it?
I think it was pointed out that, in change, I think we all need to be involved and engaged in this process. I think, we recognise that, as we said, diversity and leadership is incredibly important. And in order to drive some of these changes through, we need to have everybody on board. This isn't just to get this change, we need to have leaders across all organisations, and that was really pointed out within the panel. So we're hopefully seen as we can contribute and help change that paradigm.
David?
And so I think the important thing I brought to this was someone who advocates to enhance the role of women, not only in medicine but also in the broader community, and to drive towards equality across the community. I think one of the very important messages that came out of this was actually something that Dara said around the idea that she actually used the talking about breastfeeding rooms. And she said, I'll never need one, but I'm going to advocate for it. And I think that's a very important point, to say, yes, there may be personal benefits in some things, and there will be community benefit about much greater engagement for women in medicine and also across the community. But probably more importantly, that those who are trying very hard to advocate for women will look at issues for where there is no personal benefit, but that should in no way undermine your efforts in trying to achieve equality.
I suppose the other important point is that we are both people who have come through a system that actually we haven't had barriers. Realistically, every time I've gone for a position, there hasn't been a great big barrier in front of me to actually get those positions. So I think, and now where I sit, I see all of the barriers that are put in front of our female clinicians, but not only female clinicians, but clinicians of different racial and cultural backgrounds as well. So knowing, my experience has actually made me realise, I think, with a lot more detail about and hearing about other people's experiences has given us a completely different view on how we need to change.
Would you, while you haven't faced barriers, do you feel you've put up barriers for people? Have you watched that in action and seen yourself be able to get ahead at the advantage of someone else?
Have I seen myself get ahead at the? Look, I would have to assume that probably has happened. I suppose at the time I wouldn't have been acutely aware of that, but I do know that. For example, going for jobs as a trainee, there was never any issue about getting jobs. I mean, admittedly, it was different as far as, the time. I was a trainee quite a long time ago, believe it or not. But certainly, I'm much more cognizant now of the challenges of our trainees and the barriers that are in place for them, for example. And so, reflecting back, at the time, I may not have realised that, but I'm sure if I look back, I could probably think of examples where I was, tapped on the shoulder for a role that somebody else might have been going for. I can't give a specific example, but I'm assuming that probably has happened.
So tell me about, because you're the head of the Australasian College for Emergency Medicine, when you have your board meetings, how many women are in the room?
Not many.
How many is not many?
None. So this is part of the reason that I'm here. Is that when I came into the role as the president, we made some changes. Our organisation made some changes to its structure, its governance structures a couple of years ago, and put some rules in place that everybody at the time thought they were fair and reasonable. And when I came into the position, I looked and said, well, there's clearly, and we heard very clear, there was clear evidence they weren't working, and we heard very loudly from our members about the fact that we have a problem, and it was very, very difficult for people to jump through those certain layers to get to a position on the board. So we're in the process right now of changing our constitution We're hoping that will be voted through in the next month or so, and we really want to open up opportunities for any member of our college to be able to be nominated for a position on the board.
Are you talking quotas?
We haven't actually made a decision on quotas, but we are confident at the moment that we will have anywhere between 30 to 40%. By 2020, we're aiming for 40%. But again, the next step will be obviously let's review it. If it's working, it's great. If it's not, then we'll look at quotas.
And there have been other issues around discrimination in emergency medicine and other things. What are you trying to do around diversity? There was a big issue. You had an investigation into your testing process, etc. Where do you think, is it just embedded and it's a long way to go? Is there anything particular to emergency medicine? Because Dara was talking about that.
I think if you look at any college, I think they'll have these issues. I've no doubt that every college is looking at this and looking at their processes and realising they have some internal processes that need to be refined, need to be looked at. We still have an ongoing problem. I think I think in our training programs we're very inclusive and diverse. Anybody who wanted to do emergency medicine training could get into our training program. So there was no entry criteria. So in fact we're very inclusive. But we do have issues that we need to constantly redress around our assessment programs and about our examination programs. I mean, we are constantly trying to refine them to make them as fair as they can be. But I think, as I said, I think any college is probably going through similar processes and really looking at their selection and how they, support trainees through the system. And of course, it's incredibly important we get it right because people do invest, 8-10 years of their life to get to that fellowship point. And if there are issues that are discriminatory around the assessments of their progression through training, we need to make sure we fix those.
David, you talked, and I may be misquoting you in its context, about you were saying, where do we go from here, that it's a good thing for people to go find 5 things they want to do and go and find people to do them with. What are the 5 things you want to do?
Well, I'll step back a little bit. It's more the concept of having a bundle of things. If you're trying to make changes, you could focus on one thing. But if you can find, several evidence-based things you put together as a package, and then test that, I think it's very important as we move forward from here to do health services type research to find what is success, what is failure, rather than just implementing something and saying, oh, this must be a good idea because it sounds like a good idea. We actually need to test it. So that what I was trying to put together was the idea that we find, say here in Victoria or here in Melbourne, we find a relatively small number of hospitals that are prepared to take part in a program to look at implementing and testing changes. I think following on, in fact, the discussions we've just had after the session, the idea of having heads of department that rotate more frequently, and going back to our own College of Anaesthetists, our presidents have a 2-year rotation, and we've had a number of women who've been presidents of the college, and I think that with a training program, presidency, and then go on to have an ongoing role as a senior member of the college, and that's a sort of model I think could be applied to hospital departments, where you have a relatively brief tenure as head of department, you have up-and-coming people, and I think it's, so part one of the bundle is that you have a short tenure as head of department. Part 2 of the bundle is that you have a relatively, a set of an executive, probably 3 or 4 people. Ideally, if you had 4, that 2 are women, that you insist there are women coming in, and that you then look at, they then rotate through. It's important that the person who rotates out of head of department, they can retire or leave, but if they're going to stay, they play a positive contribution. And so the new head needs to have their own independence and not to be overseen by someone who may be dominating, but also then perhaps there's a role for that person to provide mentorship for the up-and-comers, but B, to be a senior experienced clinician within the department. So I think if I was to look at a particular thing that is probably doable, so if you went to several hospitals and say, righto, come up with 2 or 3 departments who would be prepared to do this and test it, and look at whether it's implementable.
I think the important thing there was that we recognised the importance of leadership within our health systems, and the way I think leadership positions in hospital systems and medical units has really been through a system of progression through your clinical work, and then some research, and then you become a professor, and then all of a sudden you're a director of a unit. Now, that doesn't mean you actually have any leadership qualities. It means you're a good clinician. It doesn't actually mean you're a good leader. And so I think leadership in this day and age of change, particularly when we're trying to address issues around gender equity and diversity, I think that needs strong leadership. So we need to actually ensure that our people are in those positions actually get that leadership training.
And I very much agree with that. I think another component, as we do with trainees, is to give them feedback. You know, the idea that yes, that, you know, so particularly that emerging group of leaders as sort of the executive of a department, that they're given mentorship, you know, by amongst others the previous heads, but also the possibility that you say to someone, you are not the right person to lead. And I think that's really important, because you sometimes get these really dominating, difficult personalities, and they rise to the top and they stay to the top.
Yeah.
I mean, Dara used a fantastic term, the king. They act like kings and they stay like kings for 10, 20 years. That's, I think, if we're going to get significant disruptive change, that is something we could do right here, right now. And I think it would be a very positive change. But having said that, we do need to test that it does what we think it does.
And it's a really interesting thing, because it's a protective measure, of course, but Simon, it's also been raised, that rotational thing for college heads. You've been involved in trying to bring about transformation at ASAM.
Yeah.
You'll move on. What do colleges do? How do you maintain that transformation?
Yeah, I think there is significant overlap in the way we roll through our presidential roles. So, for example, John Bonning, who is our next president, we're working together for the first 12 months, and then I'll work with him as immediate past president. So the two of us work together for 2 years. And so we're very much aligned, I think, and understands what we're trying to achieve. And so, you know, I think first of all, the mentoring process, I think, works really well. But of course, my role as immediate past president, I'll still be there for 12 months. So many of the projects we're carrying on now, I'll continue to work with for at least another 12 months post-presidency. But the other thing, I think, is going back and, again, we need to embed things like our leadership training programs. And as a leader, the other thing we need to do is ensure that people in our committees and people who aspire to make change feel empowered as well. I mean, my job is really to actually inspire the next generation of clinicians and some of the people in that room to say, well, you know, I feel empowered to step up and actually challenge the system and give them that support. And I think that's a really important thing that I can offer to our younger face centres who really want to challenge the system. You know, stand by them, give them support, but let them, you know, try and lead the charge.
And now, a very quick one. Out of today's conversation, you were the men in the room and at the table. What's one thing you'll do differently as a result?
Listen to more of those 4 amazing people on the panel. They were just brilliant. I think do more of actually being a facilitator of change. I think one of the things we need to be very careful of this, you know, I'm not here to work for myself. I'm here to work for the people who elected me into the position. So, you know, I need to work for them. So I think more listening, more collaborating, more empowerment of the people who want to make change. I think that's my role.
Okay.
I think it's a day-to-day thing. So I have university staff, but I also work very closely with trainees in the clinical setting. And I think to say to them more frequently, is everything okay? What can we do differently? You know, and I think, and this is particularly for the trainees, to say, are there problems? We have the other interesting feedback, and I think the emergency medicine people have it too. We have the nursing staff. So we actually have this secondary route of feedback, which helps. But I think where I'll go from here is to be much more proactive in engaging with the trainees, both men and women, about how things are going, and particularly are things not working for them.
Thank you both very much.